lactation. So we now also have to talk about some of the general principles. So mastitis, that's the inflammation of the breast or chest, okay? And we're going to talk about different ways of looking at that. And we do know that there are several different breast conditions. It is no longer just a term for that infection that requires antibiotics, but rather it's inflammation and edema. Edema is another term for swelling in the tissue around the milk ducts or in the milk ducts, okay? And we're going to talk about that. And then hyperlactation, which I already led to, that oversupply of milk, more than what our babies need, and mammary dysbiosis, okay? And so mammary dysbiosis is when we have an increasing number or too many of the bad bacteria or the bacteria, the pathogens, the infection-causing bacteria, and we have disappearing, decreasing amounts of that healthy family, that good bacteria that we want in our body. So these are the different ways of looking at the spectrum. So we start with that hyperlactation and that dysbiosis, which we just talked a little bit about. And if we kind of don't, approach these things and get these things under control, that can lead to ductal narrowing, inflammatory mastitis, bacterial mastitis, and all the way down to an abscess. And that's where we don't want our patients to get, right? We really want to be intervening up in this area to help prevent all of these things. And this is the work, this is from Katrina Mitchell, and she is one of the authors of the new protocol. This picture is actually from the protocol itself. If you haven't printed it off, I highly recommend that you do print it. There's great pictures, there's great figures that really are gonna, help you to understand these things even more. And when this protocol first came out, I was like, oh my gosh, there is just so much here, so much to wrap my head about. It really took me a long time, and reading through it several times and really diving deeper to really understanding what they were talking about. So if some of these things seem a little bit like, oh my gosh, I don't understand this, go back and look at that again. I'm going really fast because we have a lot of information to cover in 45 minutes. Okay, this could probably be a 2-hour or longer talk all by itself. But we know that there are certain things that either are going to predispose or protect us in that milk microbiota and breast microbiota. Things such as host factors, and that can be autoimmunity. So think about how many more of our patients are having autoimmune disorders. And here we go, breastfeeding related factors, pumping, HACA use, creating those big stashes and that hyperlactation. Microbial factors such as our parents' metabolism, and do they have antibiotic resistance? And then also things such as, do we take probiotics? Do we not? Have we had antibiotic treatment that for some other thing that has caused some of that bacteria in our body to decrease? So you can look at that a little bit more detailed and look at all of those things on your own. But we really do have to start with the basics, okay? And so that early postpartum engorgement. Now, this is actually a physiological process, a biological process that our body really is meant to go through. Now, we don't want it to be unrelieved, and we don't want it to be, completely uncomfortable for our parents, but we do want some of this engorgement process to occur. And so this is actually the result of what we call secretory or secretory activation. That is the new term for lactogenesis 2. Lactogenesis 2, remember, is when that milk surges, or when some people will say when the milk comes in. I choose to use when the milk surges because colostrum is the first food, the first milk that our body produces, and I don't want parents to think that they don't have milk yet when they're feeding their babies. This very often is going to present as bilateral pain, so both breasts at the same time, having areas of firmness and swelling. We can see in this picture here, this breast is so very swollen and shiny. There's hardly any space in between the two breasts. And we can even see some redness here starting to form. And we'll talk about that here in a minute. You might have been taught when you were first learning about engorgement. I still remember sitting in the CLS class and being told mild, moderate, severe. And we don't want the breast to get to the severe stage, kind of when you're feeling the breast tissue, what does it feel like? This typically for most of our families, our parents, is going to occur between postpartum days 3 and 5. There's always going to be outliers where it may occur a little sooner or a little bit later. Anything that has potential to decrease or delay, I should say, the milk surge also has is going to delay when that engorgement occurs for the parents. So things such as a cesarean birth, a large blood loss, lots of swelling in their feet caused by some of the extra IV fluids and medications, which we'll touch on as well. So here, our goal is to keep this breast the happy and healthy breast. So we're still there. We're still happy. We're still healthy, although parents may not feel it's very happy, but we are still in an okay spot. But unfortunately, sometimes parents don't understand what's going on, and even healthcare doesn't understand what's going on. And so we tell parents, we need you to pump, we need you to move that milk, or they think that all this fullness that they're feeling is the milk in the breast. And really, that's not what's going on. Yes, there's an increase in milk, but all this fullness that they're feeling is actually related to lymphatic, congestion or an increase in blood flow. So pumping and trying to remove more milk is probably not going to yield a lot of milk, number one. And number two, it's going to tell the body to make more. Uh-oh. Did my screen just go away?
It did.
Oh, well, let's try that again. Are we okay? Can you see it again?
Oh, there, it's back.
That was weird. It just, something popped up and said, something about sharing something else. So anyway, where we were back to is, so oftentimes what we will tell parents is, go ahead and move. You got to pump to comfort. Well, yes, we want them to be comfortable, but we have some other things that we can do. We really don't want to be doing a lot of pumping per se, or the Haka use. And we're going to talk about that a little bit more. And that redness that we see is not infection, but actually that is from what we call that alveoli, that alveolar distension. So the milk sacs are kind of filling, that we have swelling in the breast, and that's putting tension on all of those things. And that's actually what is causing the redness in this situation. It's not infection, but sometimes parents will call about that. They'll tell the physician that they have redness on the breast, and automatically antibiotics will be given, and that's not best practice as well. So what do we want to do? Well, starting from the very beginning, before the baby's even here, we want to try to avoid using excessive amounts of IV fluids. Medications such as Pitocin are what we call an antidiuretic and can hold on to fluid in our body, which increases the swelling, not only in the breast or chest, but also throughout the body. Encourage rooming in, because we really want babies to be feeding on cue. The protocol uses the term feeding on demand. I choose to use feeding on cue because when I hear demand, that's like I'm demanding something. So in baby language, demand would be crying, right? We don't want babies waiting until they're crying, because that can make latching more difficult. It can also make it more uncomfortable for the parent. If we need to remove some milk to help the baby get latched on, or to make the parent more comfortable, we actually would prefer to do it with hand expression, because we're going to use smaller amounts. Parents are not as inclined to continue to be hand expressing for 15, 20 minutes. They are going to hand express for a shorter period of time, therefore removing less milk, therefore not adding to that possibility of hyperlactation. We also could do reverse pressure softening. If you're not familiar with that, there's lots of great videos on that. But basically, we're using the fingertips to compress backwards to try to push that fluid back away so that the nipple can come out, and that makes that area, the areolar and nipple, more graspable. And remember, we need a graspable breast for the baby to get latched deeply and comfortably and move milk well. We also can do that hand expression, like I said, or if they really don't want to, they're not comfortable using hand expression, because some of our parents may have something in their history, some abuse of some sort, where they're really not comfortable touching themselves or having you touch them either. So it's always important that you would ask permission before you ever touch or hand express or any of those types of things, and they may be more comfortable with having the pump do that for them. But once again, small amounts, just enough to soften that area up. We're going to talk more about lymphatic breast drainage later, and then our friend ice, okay? And you might be thinking, oh, wait, ice, that's going to make the milk go away. No, what makes milk go away is not removing milk. Okay, so as long as they're feeding their baby, or if they're an exclusive pumper, or they're needing to pump because their baby's not able to feed at the breast or chest, then we need to, we need to make sure that we're moving that milk in that way. But if they're feeding, then milk is going to continue to be made. Ice does not make milk go away. What ice does, it decreases swelling and it decreases inflammation, which is exactly what we're wanting to do. We also could use cabbage leaves. One of the things that we want to make sure that if we're using cabbage leaves is that they're washing the leaves first, because it does have potential for carrying listeria. And we don't want babies and parents to be exposed to that. The research doesn't really show that cabbage is more effective than ice, and many of our parents are going to have access to ice at home and would not have to go out and purchase anything else. So now we'll kind of get in a little bit more into, what we would expect, that expected flow of the milk, how this is, all supposed to work. So I want you to think of the ducts, the milk ducts in the breast, as a highway. Okay, those are the highways of the breast, getting the milk from point A to point B. And Dr. Heather Johnston uses a lot of analogies, and she describes, the mastitis protocols and compares it to the highway system. And so you're going to see a little bit of that throughout this talk. And so first of all, milk is made and stored in, that alveoli, and those are all grouped together and make lobules of the breast, right? Then it's going to flow from that area through the ducts to the nipple and then to the baby. And we want good bacteria, that healthy family of bacteria in the breast and in the milk. And that's going to line up in those milk ducts. So she describes it as this road here. So our good healthy bacteria is all the spectators we have at this motorcycle race. We still have lots of space, lots of ability for those motorcycles to move from here to there without having any complications or any interference from any of these spectators. And that's what our goal is those wide open spaces to make flow go well. But then things can start to go awry, okay? And so now we have bacteria that's starting to get out of balance, and there's inflammation to the walls of the duct, and that causes more swelling and more narrowing. And so now those spectators are starting to get into the way.
Mastitis and breastfeeding.
Can somebody please put themselves on mute? I'm not sure who's talking, but I need you to mute yourself, please. Thank you. So what we know is those spectators, so aligning up. And so now the bad bacteria is starting to increase. So we not only have our good bacteria, but now we have our bad bacteria, and that's starting to close in on the milk ducts. And that is meaning that's those spectators that are getting in the way. And as those roads start to narrow, that milk duct starts to narrow, it makes it more difficult for the milk to flow, okay? There is that balance of bacteria that gets out of whack. And when we have that, we can have a sticky biofilm that will actually form in the ducts, and so what happens is we have that biofilm forming, and it's sticky, and the components of the milk, such as fat, like to stick to that biofilm. And so that's why for a long time, the thing that you see here when patients would pump or when their babies unlatch and they have that stringy stuff coming out, that's why we thought that it was actually related to this plugging that you see there of a duct that was causing all of these things. But that's not really what's going on, okay? So here's our ductal system. So, comparing this to these big city highways, they're interwoven, there's many of them, it's very complex, and our breast is the same. The ducts of the breast are not a straight line. It's not from point A to point B like a pipe or like a tube. Instead, we're going to see that they're innumerable, it's interlacing or interwoven together. And so that's why the idea behind dangle feeding or pointing the chin towards the duct that's plugged may or may not work. And this is a picture kind of showing you the inside of the breast through imaging. So we have our nipple over here, the way the baby is going to compress here and get that milk to release out through the nipple, our main milk duct, and it goes into all these different areas. And you can see how intricate that system is and how just one little area being plugged here by what we saw on the previous page isn't really, making a lot of sense. But instead, it's microscopic narrowing or edema of this surrounding tissue, causing those milk ducts to become smaller and the bacteria getting out of whack, causing that. So once one person once described it, so we used to think it was kind of like having a tube of toothpaste where your kids left the cap off, and so it got a little dry and you really had to push hard to get that out. And we used to think that that's really what we needed to do to get that plug out, but we're going to see that maybe that wasn't quite the right way of going about things. So we're still at the point where we're wanting to decrease that inflammation, and we're going to talk about ways to do that as well. But if we don't decrease that inflammation, we didn't encourage them to use ice or ibuprofen. We encourage them to pump. We encourage teat. That is going to further increase that inflammation, which is going to make the milk have to move through an even narrower milk duct. And eventually that area can, we're going to see in a picture coming up, how it can actually make it become impassable when that bacteria starts to overtake the breast. Okay. And so we have this increased swelling, we have redness and heat, we have tenderness, and that milk starts to back up. And our patients may start to feel a little yucky. Okay, and they feel bad. And so this picture here, we have the mountain spectators, we have people walking, and we have a more narrow road. And in order to safely navigate through this area, they're going to have to slow down. Traffic is going to have to slow down and go single file. Instead of having our 5-lane highway where we have lots of move to room and go around, now we have this very narrow space that requires this. We're not to the point of infection quite yet. And this is not a great picture. It is from the protocol itself. It's figure number 2, but I just wanted you to be able to see it to hopefully understand a little bit more. So up here, this is all of our good, healthy bacteria. The colorful stuff is what we want. We have that really smooth, that milk is flowing really fast. We have lots of wide open spaces. And if we did a cross section, this is what it would look like. But then when we start to get infection and inflammation, the bad bacteria or the pathogenic bacteria is this black stuff, okay? And we see it starting to get out of whack and taking over. And all of these little like eyeball looking like things are inflammation in that mammary epithelium or in the breast tissue itself. And then we can see how now we have this inflammation and we have this narrowing duct. So now the milk has to make it through just this little area instead of up here. And if we continue to not be able to get things under control and help the parents, then we get to the place where we have this obstruction. Okay, we have pressure, we have edema, we have all of that inflammation still, and now that duct is pretty much completely blocked where they cannot get that flow. These are some of the common symptoms of ductal narrowing. Now, the old term was plugged duct. So that's why I keep going like this when I say plugged, because now we're calling it obstructed duct because of what we just talked about in that previous slide. This does typically occur on one breast, and it is an area of what we call induration. And induration is thickening or hardening of the soft tissues of a body part, and that can result is the result of an inflammatory process. So the breast might look or feel hot, swollen, and that redness. The redness is still not from infection, but instead from lymphatic congestion. So we have too much lymphatic fluid in there, and we have edema or distension of our alveoli tissue. Okay, they feel well, generally speaking. They feel something's off, but they don't typically have a fever. But the milk can be slower on that affected side. And we need to realize that those tender lumps and bumps that they're feeling in the breast, it's not actually that plug that we thought was there before, but instead full milk sacs because the milk can't flow. The new evidence, how do we prevent this? Okay, so these are some of the recommendations for prevention. That 4th trimester care. So remember, the 4th trimester is the 12 weeks following the birth of the baby. So talking about ways to decrease stress, ways to get more rest. How can friends and family members be of help to them in ways other than feeding the baby? Educating them on what's normal, that engorgement process, letting them know that they are going to feel lumpy, bumpy glandular tissue in the breast in the early days as that milk is filling. And that's not necessarily that plugging that we once would have thought, okay? And that if they sleep for long periods of time, their baby gives them a 6-hour stretch for the first time and they wake up and their breast is red. Well, that redness is from that distension of the milk sacs. It's not from infection. Okay, so those are things that are important to talk to them about. We really want to be focusing on feeding on cue and not aiming to keep the breast empty, which is very different than what we used to talk about when we were talking about mastitis. Minimize that breast pump usage because that can increase, trauma and inflammation in the breast. Now, if we need to use it, yes, we have a baby who's not feeding well. That's not what I'm saying. We're talking about a baby who's feeding well and doing a good job and not needing any supplementation or having any complications of any sort. It does call for avoiding nipple shields. And I know that I use nipple shields in my practice, but it shouldn't be our go-to where we're putting them on baby or parents to use without a medical reason to do so. And if we are using them, we really should be following them closely. The protocol says, that there's not really a lot of evidence that it really does help, with breastfeeding. I think any of us that work in lactation feel like it saves the breastfeeding journey for many of our patients, but we just have to be careful with that. And then the treatment of hyperlactation. And there's an actual protocol number 32, that talks about that because we need to decrease the number of cars on the highway. When we have too many cars, that's not going to flow, even if we have a 5-lane highway. All of us might have had the experience of being in big city traffic, right? And even though we don't have any closed lanes, if we have lots of cars, it makes it difficult to navigate. Now, prior to this protocol 36, these were the treatments that were typically recommended. Castor oil compresses, Hakas with Epsom salt using a toothbrush or anything in the house that vibrates, dangle feeding, pumping and nursing more. We got to keep that breast empty, keep that milk moving. Warm compresses, massaging, really getting in there. Analgesics, rest, and stay hydrated. And as we move through, I think you will be surprised that many of these are no longer part of the recommendations, and we'll talk about why. So now let's talk about what is the new way according to the protocol. So the first thing is physiological breastfeeding. So we need to be feeding the baby responsively. So feeding as often as the baby would ask to eat. We really don't need to be increasing the number of feeds a day. We just want to follow that baby's lead. Now, once again, we're talking about babies who are feeding and thriving at the breast. We don't want to, if the baby doesn't nurse for a certain number of minutes, we don't want them pumping to equal that number of minutes. I have parents tell me that some of their providers are saying, if the baby doesn't eat for a full 10 minutes or 20 minutes, go ahead and pump for that additional time. That's asking for more cars to be added to the highway. We also used to teach always start on that affected breast first because we really want that milk to be moving, right? And we want to keep that breast empty. But when we do those things, it doesn't let Phil, the feedback inhibitor of lactation, go to work and do the job that it's meant to do. Phil helps keep our milk supply where it needs to be. When our babies are removing milk well and we're physiologically breastfeeding, we're making milk to what our baby is asking for. When our baby's feeding and then we're using the Haka and then we're pumping, we're telling our breast to make more milk than what we really need, setting them up for that hyperlactation and that dysbiosis. So when we are constantly keeping the breast empty, Phil is going to say, make more milk, which is why we don't want to be doing that. We talked about that already. We also want to treat the breast gently. It calls for avoiding deep massage and vibration. In the past, we used to say, oh, you just really got to get in there and really massage that area. And boy, it's going to hurt like the dickens, but you just got to do it because that's what's going to get that plug to clear. And we know now that actually increases inflammation and trauma and increases the risk for developing to a bacterial mastitis and or abscess. Right? All the things that we might have been doing could have actually been potentially impacting our patients negatively. And we do want to wear a supportive bra. And one of the analogies someone once made is kind of like when you were a teenager and you had a red pimple and you thought it was going to make it better to pop that, right? But what did the popping it do? It really just made it more red and angry and potentially increase the risk for that acne to spread in that area of the body. So why these changes, right? Well, now here we have our 5, 6, I don't even know how many lanes highway that is. And look at all those cars. When we have narrow roads and too many cars, we can't get through. And the milk is the same. It can't get through those narrow ducts with all that bacteria or dysbiosis in there as well. And when we're increasing feedings, when we're keeping the breast empty, when we're using the haka, we're adding more cars than what the baby is asking for to be in the breast. And then she describes using vibration or that really deep massage as an earthquake in the breast. And so it actually causes that tissue to break down more and kind of fall down on itself and leads to more damage than what was there before. So what are we going to do? Anti-inflammatory such as ibuprofen, analgesics such as Tylenol or acetaminophen, and ice. These are the things we want to be starting with. The protocol gives recommendations for the dosages and the frequencies for those medications. And it also, talks about some other things that we'll get into, that are good resources. Even if you're not a prescribing provider, it is good to have information on these things so that we can provide guidance to whether it's healthcare providers, providers that are asking us or our patients what they can ask for when they call and talk to their provider or physicians.
Hi guys.
So ice booby. Okay, so this is an actual name of a product, and so this actually can be heated or cold, but in this in what we're talking about, we want it to be ice. Remember why? We want it to decrease swelling and inflammation, and it also helps with pain relief. Ibuprofen is an anti-inflammatory and pain control, and Tylenol or acetaminophen controls pain. They can use ice as long or as often as they want. We just want to make sure their skin is protected, and that's why these come with these little covers that go over it so the breast is not exposed right to the cold. We also know that we can use just frozen peas and corn in a Ziploc bag. You can Google how DIY how to make ice packs. 1 part isopropyl alcohol to 3 parts water, just thrown in a bag, creates kind of that gel and works really nicely as well. So this is what the inside of the duct looks like. So when we have lots of that distension, we have increased blood and lymphatic, we have these very narrow ducts where that's going to slow. But when we use ice to reduce that edema and increase the blood flow or reduce the blood flow, that is going, and also letting Phil do its job, so not removing more milk than what we need, that's what's going to cause these milk ducts to widen and that distension to go down. Lymphatic breast drainage. I'm going to show you a little video from Lucy Weber. She is a lactation consultant from the United Kingdom.
Okay, so breast massage and lymphatic drainage. So for mastitis, engorgement, blocked ducts, that type of stuff, it's been long said that you should really get in and massage the breast tissue and really get in there and try and get milk shifted and massage. And actually that really isn't helpful. The breast can get very swollen, lots of excess fluid going on in there, which can make things very uncomfortable. It can restrict milk flow, and we really can help shift that actually with the massage we do, but it's quite different to what we were thinking previously. So the lymph system is a way that your body naturally drains away fluid, and the massage that we can do can help with moving that excess fluid in a way towards that natural drainage system. So firstly, getting on in just above your collarbone and doing kind of 10 circles just above your collarbone comfortably massaging. And then the same thing in and underneath your armpit. And these are your natural areas that are going to help with your with drainage from your breast. Once you've done those, you can get on and start thinking about the breast tissue. The key is to only ever be handling and massaging the breast in a way that is as firm as you would stroke a cat. You really don't want to be very firmly handling your breast at all. It should be gentle and as comfortable as possible. So we're actually working from nipple outwards, not down towards the nipple. We want to go from nipple outwards up towards the collarbone or out towards the armpit, and it's gentle strokes or gentle massage, really comfortably up towards that armpit, round and up towards the armpit or up towards the collarbone, and just doing some nice sort of sweeping movements just to really try and start thinking about helping that fluid to drain away, which is going to get things much more comfortable. You can also do some actual movement of the breast itself to help with this. So actually lifting and gently rotating around the breast in a few circles, either kind of way can be really quite useful for some people as well, although it does feel understandably a little bit strange. So doing that, and then going back up into the armpit and doing some massage in there again and in there. So give that a go and see if it helps.
So the last things that she was talking about were what we call breast gymnastics, and that is the work of Maya Bowman. So you can also Google breast gymnastics and get that as well. Other recommendations are treating blebs, but avoiding unroofing. Unroofing is using your fingernail, a needle, anything to open this area up, because that increases inflammation and risk for more trauma. Instead, using a cotton ball soaked with olive oil or coconut oil, lecithin, 1% triamcinolone cream, which is a moderate potency steroid that does require a prescription. The ultrasound, it uses thermal energy to decrease inflammation and swelling. Antibiotics, we really don't want to be using yet. We want to reserve that for bacterial mastitis, considering probiotics, and then do evaluate our patients for perinatal mood and anxiety disorders, because that increases their risk. Avoiding saline soaps, the castor oils, the Haka with the Epsom salt, because it causes more tissue breakdown and maceration. They also call for avoiding routine sterilization of pumps. And so I know the CDC calls for that, so we have to follow whatever our organization is requiring us to follow. But instead, they say just wash with hot soapy water and then sterilize only, occasionally or if there's need. So what about the idea of heat? Well, remember, heat is going to cause more dilation and increase blood flow, and that can make those ducts even more narrow and potentially increasing inflammation. But some of our parents may actually feel that helps them when they're feeding the baby or when they're pumping. And so using their own personal judgment, but really limiting that time. We certainly should not be encouraging parents to get into the hot showers with letting the water beat down on them, and that's going to make the milk spray everywhere. Maybe for some, but for others, that's only going to make the swelling much, much worse. And certainly not using heating pad to the breast to help with engorgement, which is what one of my patients was told a couple weeks ago. She couldn't get it under control. We switched to ice and ibuprofen, and very quickly she was getting relief. Now, inflammatory mastitis, we have narrowing, worsening inflammation. We have more erythema, which is that redness throughout the breast, and they start to get some systemic symptoms such as fever and chills. But this can be present without infection. And so this is the situation where the parent does some of these other things and the mastitis goes away. They do not need an antibiotic for it. But if this is lasting more than 24 hours, their symptoms are not improving, they do need to call their provider. This presents as cellulitis, which is even more redness all throughout the breast. You can go through different quadrants, and this does require antibiotics and or probiotics to improve that, because it continues to go down that spectrum and inflammation gets worse and worse. So we do want antibiotics. Like I said, it talks about medications, durations, dosages in there. It also talks about how to do a milk culture. If the patient is not getting relief within 48 hours, we need to consider a milk culture and a medication change. Considering probiotics, this is a controversial part of the new protocol because there's really not a lot of evidence to support that. Cochrane says that there's really no high quality randomized controlled trials, and we would actually have to look at each individual strain and species of bacteria. So bottom line is it may or may not work, certainly isn't going to hurt anything. But we want to avoid progression to an abscess, which is an infected, hardened, well-defined area where it actually the infection walls itself off. And so there, it fills with pus here, and that antibiotic can't get to it. Sometimes their systemic symptoms, fever, chills, will actually improve as that walls itself off. It's important to do a good history, clinical exam, and ultrasound for diagnosis. We'll need a needle aspiration to see what bacteria is in there to know how to best treat. That may need to be done several times. So often there'll be a procedure called an incision and drain, where they will actually leave a drain open and that breast tissue open to allow that bacteria to clear. They can still provide the breast milk, they still can breastfeed, they can still pump, as long as that baby's mouth or the pump does not come in contact with the area of the abscess. They typically need antibiotics for about 2 weeks, and they will take a while for this to heal, and they may still have some inflammation there. They should be followed numerous appointments with their provider, as well as imaging to ensure that that area has improved. So our goals are to keep all lanes open and to really clear out that space to allow traffic to flow smoothly in the breast. There are some different adjunct protocols that you can look at, and they also have a really good parent handout that describes all this in parent language. There's more on these different things in the protocol, but we simply don't have time to discuss those things today. And then I was also asked to touch briefly on antenatal colostrum harvesting, and is that safe? So there was an RCT done of 635 women with low risk pregnancy complications. So I'm not talking about people who have cerclages or a history of preterm labor or placenta previous. But if they were low risk, it really showed no harm in starting to pump after 36 weeks gestation. Patients that might benefit from that, any diabetic patients, so gestational, type 1, type 2, if they are having high blood pressure, any reasons that they might be delivered early, or if they've had a baby in the past who really hasn't fed very well, such as a tongue tie, or they've had any surgeries to their breast or chest, or issues with milk production. Expressing during pregnancy, they always should be talking with their healthcare provider before starting. It helps when they're in a nice warm room, relaxed, wash their hands first, which is key, and then gently doing massage. Remember, no more than petting a cat or applying lotion to your body, and then using that hand expression. And there's great videos on hand expression. There's lots of different techniques out there. And then they would kind of go back and forth. If it's causing any pain to the breast or chest, they should stop. When do we start it? Every protocol is a little different, but generally 36 to 37 weeks, 1 to 3 times a day, about 5 to 10 minutes per session. In our area, we typically recommend hand expression more than pumping, but that literature that I quoted first did talk about pumping. Parents can get supplies if they just Google, collection of colostrum during pregnancy, syringes with caps. HACA actually has a colostrum collector. And when I was Googling that, all kinds of kits actually popped up that parents can purchase for doing this. But we have to store that milk until the baby gets here. So we would want to put that in the coldest part of the freezer, dating and labeling them. They can even put them in Ziploc bags in a Rubbermaid container. I encourage people to call the hospital where they're going to be delivering and find out if they will have access to a milk freezer to put their milk in. And if not, they may want to bring smaller amounts with them and then have people bring more up to the hospital if the need is there. That thawed colostrum does need to be used within 24 hours of thawing, and unfortunately sometimes inductions take longer than 24 hours in some of these situations, and milk has gone to waste. Is the milk collected safe to feed the baby? Yes, yes. And again, I say yes. All milk is good for the baby. You know, that it's the same milk that would have been in the breast if we wouldn't have hand expressed, and the baby would have gotten that milk when they are there. It's just making sure that we are using good hygienic practices with washing hands, clean, you know, syringes and things that we're saving it in and following the storage guidelines. And there's some references on there. So thank you for your time. I hope that that clears things up a little bit and gives you things to think about, and a little bit more understanding of the protocol. I will be happy to answer questions, you know, and I can also share my email in the chat so that you can email me your questions as well.
Rhonda, thank you so much. That was so great. I learned a lot. Does anybody have any questions for Rhonda? If you have any questions, you can put them in the chat, or you can take yourself off of mute and ask. Can you share the reference slide again, Rhonda? Somebody is.
Yep. The reference for the colostrum collection. Know what you guys are wanting. Let's see here.
Nancy, you're right about this being the opposite of what we were taught and what many of us did for years. So, you know, as Rhonda mentioned in the beginning, it has been kind of hard, you know, for a lot of people to wrap their brain around, but it all very much makes sense.
Did you guys get the references? You're welcome to take a picture of it if that makes it easier. Can't write that fast, I'm sure. And there's a lot more out there. This is just the ones that I put on the slide.
Ashley Strew is asking, where do we get resources and handouts?
As far as the mastitis protocol one or the antenatal collection one, or both. The mastitis protocol, if you just go to the Academy of Breastfeeding Medicine, and you can put parent handouts in there, and it will come up. They have one on bed sharing, they have one on physiological breastfeeding and kind of helping with that. They have tear-off sheets, so if you're printing this for your own use, but honestly, you know, if we are giving it to patients from an ethical standpoint, we probably should be purchasing those. I just realized that they had those for purchase on there. I think their tear-off sheets are about $15 at you know, for I don't know how many are come in a package of them. As far as the protocols to use, there's lots of different ones out there. TCM actually had a protocol when Nicole Paul and Karen Collins were there when they took the CLS. They developed one. I have a copy of that if you would be interested in it, if you're not sure where to find it.
Alyssa Williams is also saying that IABLE has some great handouts too.
Yes, and they actually have a really good video of Dr. Mitchell doing lymphatic breast drainage that I was going to share with you, but YouTube didn't recognize it in the PowerPoint, so I had to go with something else. But IABLE is a great resource. I highly recommend them as well. Dr. English does a great job.
Any other questions or comments? Yeah, Alyssa said that those handouts are free for patient education.
Yeah.
Which organization did you reference for the tear-off education?
The Academy of Breastfeeding Medicine. So if you email me, Wudtke5, so W-U, D as in dog, T as in Tom, K as in kite, E as in Edward, the number 5 at yahoo.com, and just ask for it. I can share the link with you.
Oh, Nancy said, I really think cell phone use being the norm exposes much more bacteria to the hands and breast changes the flora. That is a great point.
And that's also why it's super important when we're doing for our parents who are formula feeding or have formula feeding needs to, are supplementing with formula, why we really do provide education. And one of the things is that scoop, not storing it inside, because if we wash our hands before we do it, or we don't wash our hands and then we touch that scoop and we put that scoop back in the formula can, now we're growing all the bacteria that was on our phone and anything else. Yeah.
I guess too, when you think about the people who store their phone in their bra.
Yes.
Yeah.
Yes.
Oh, I never thought about that before.
Right. Anything else I can clarify or answer for you all?
Somebody else says, so IABLE has free patient ed handouts in the Academy of Breastfeeding Medicine costs.
I would have to look and see what if IABLE has free handouts. They have lots of good videos, and their website has lots of really good resources even for us as healthcare providers that you could look at. I could look into that a little bit more. I just saw that when I went to print these off, it did have the option of purchasing tear-off pads. So I'd have to dive in a little bit deeper to find out what permissions we have for copying them and using them, things like that.
Then somebody, Nancy, I believe one needs to have a membership to IABLE to access the handouts.
Yes, but I don't, and I'd have to look and see what actually it costs to have a membership, because I don't remember paying anything for IABLE, and I'm considered a member. So I'd have to look at that. But it's really easy to find and to go to their website. It has a link that you can click on to join.
And actually we just pulled it up and we can easily access the handouts. So Nancy said, although just purchasing an education allows membership for a while.
Through IABLE.
Like an education session from them. Okay.
And they have a lot of free stuff as well, that you don't have to purchase, that, they have lots of things on Sundays. They have lots of webinars and such that, are case studies. I find them very beneficial. All right.
Okay. Well, thank you so much, Rhonda. This was amazing. And thank you all for joining us, and everybody have a great weekend.